Welcome and thank you for viewing my presentation on leading quality, safe, patient-centered care. Here are the learning objectives that we will cover within this presentation. I will cover the principles and definition of patient-centered care, nursing strategies to ensure patient-centeredness, explore the 6 domains of healthcare quality, identify differences between quality assurance versus quality improvement, understanding risk and error, exploring the 7 aims towards a culture of safety, difference between multidisciplinary versus interdisciplinary care, and finally, review the nursing roles as a patient care team coordinator. Now we move into the overview of the patient-centered care model. Judging from these cartoons, what do you think they all have in common? The common theme was that approach to care was rather disconnected, culturally insensitive, and not very personable. So what is the meaning of patient-centered care? The Institute of Medicine defines this principle as care that is respectful of and responsive to individual preferences, needs, and values, and ensures that patient values guide all clinical decisions. It is important to also include family members, which establish the patient and family-centered partnership with care providers. The key takeaway is to shift from doing for to doing with when caring for patients and their families. This is the basic patient-centered care model to depict the dynamic between patient and other members of the multidisciplinary healthcare team. As you can see, the patient serves as the focal point, integrating all members towards the planning and implementation of care. To better understand patient-centeredness, let's review a more specific breakdown of key dimensions. First, providers must focus on the patient experience, which emphasizes effective communication, compassionate care, and the patient's own understanding of the diagnosis. Then it is patient partnership. This is the relationship where we as providers ensure that their needs, values, and preferences are respected. Although we may not always be able to accommodate, this is what we should strive for in order to promote individualized care. These are the 2 dimensions of patient-centeredness. Keep in mind, by no means does this indicate that the patient should control every aspect of care, but nurses should understand that the patient is expert about themselves and nurses are expert about the nursing practice. What patient-centered care indicates is a successful collaboration of patient and nursing expertise. Studies show that orienting healthcare around the preferences and needs of patients has the potential to improve patient satisfaction with their care as well as their clinical outcomes. Patient-centered care also has been shown to reduce both underuse and overuse of medical services. Specific nursing care initiatives have been implemented within clinical inpatient institutions to transform care practices to embody patient-centered principles. Examples are bedside reporting, hourly rounding, information sharing and patient education, opportunities for patient involvement in the clinical decision-making process, and coordinating care to accommodate or advocate the patient's expressed needs, values, and preferences. Now we explore the principles and processes of quality, safe healthcare. There are 6 domains of quality care: care that is patient-centered, safe, effective, timely, efficient, and equitable. To better understand organizational initiatives to improve quality, let's go over the difference between quality assurance versus quality improvement. The definition of quality assurance is an effort to find and overcome problems with quality by directing performance and behaviors towards more appropriate and acceptable health outcomes, expenditures, or both. Any deviation from your organization's quality standards that define what is acceptable are corrected back to what is acceptable. This is perceived by change leaders as an obsolete philosophy of maintaining quality practice because it focuses on being good enough as opposed to being the best possible. In addition, the management approach to quality assurance has been seen as punitive when inspecting and eliminating operational failures. Now we compare and contrast with quality improvement. Quality improvement is a continuous evaluation on performance, behaviors, and care practices. It challenges the status quo of how it's always been done, on existing standard operating procedures. It ignites a spirit of inquiry, of seeking new ways to improve systems through evidence-based research. This is an ongoing cycle to plan, do, check, and act towards more efficient operational processes. And finally, compared to quality assurance, this approach is more appropriate to meet the demands of a fast-changing healthcare system and adopts a just culture. More on a just culture will be explained later in this presentation. So let's take a closer look at what has been done to push quality improvement initiatives. Leaders have pushed to adopting a learning culture of constantly improving and problem solving. This mental approach transitions away from providers' rationale of, we've always done it that way, towards, how can this be done better? It empowers everyone to lead practice control, take initiative to improve practice, foster health collaboration towards team efficiency, and maintains peer accountability. It harbors a commitment to lifelong learning to maintain the knowledge, skill, and attitudes necessary to improve the clinical climate, and it collectively establishes a vision to freely share knowledge, quality improvement opportunities, operational goals, and ignite spirit of inquiry. Used synonymously with quality, we now focus on safety, more specifically safety risk and human error in caring for patients. When determining safety risk, it is important to be clear that it applies to both the patient and the nurse. In terms for patients, statistics are alarming, with 98,000 dying annually in hospitals due to errors. Identifying and mitigating risk is imperative to establish a safe climate, keeping both patients and staff safe. Frontline nurses are in the most optimal position to prevent adverse events or near misses. Identifying the source of risk is multifaceted, but commitment to communication, collaboration, and teamwork has been shown to be key mitigators. If anything, being able to practice strong surveillance skills and being mindful of your actions is at the heart of safety. When human errors do occur, the consequences can be harmless to fatal. As an example, the cartoon, the surgeon says, "Surely you could see the humor in this. I mean, the other Leslie Smith got your plastic surgery today, and you got a nose job." Another example could be depicted in this picture as well. So you can understand human error is a serious and unavoidable risk to patient safety. As such, there has been extensive and ongoing research to address this issue. Here are some of the findings and action plans that have been identified. High reliability organizations have shown to be effective in performing near deficiency-free operations. Although the term deficiency-free is impossible, the goals of simply striving for this objective has produced positive results. When planning and implementing strategies, having taken the approach that human error is inevitable, prepares the care team to always anticipate the risk and to feel free to report when mistakes do occur. Through this expectation, it places focus on systems rather than the individual who committed the error. Leaders that have adopted high reliability organizational practices realize that punitive cultures are ineffective. If individuals are punished, research has shown that errors still do occur, but are not reported. Therefore, it is important to establish a blameless culture to freely discuss mistakes. This is the philosophy of establishing a fair or just culture, where learning is balanced with personal accountability and discipline. This can also empower frontline staff to approach mistakes as learning opportunities and identify the source of the problem, which can be done by conducting a root cause analysis. We will talk more about this later in the presentation. So when we mention establishing a blameless culture, by no means does this indicate that nobody is held accountable for their actions. It is about what is fair or just, depending on the behavior behind the error. To better understand this, let's go over 3 types of errors. First, there is human error. Inadvertent action, a slip-up, an honest mistake. Providers that commit human error should be open to report and not be penalized. After all, human error is inevitable, and focus should be directed to the external environmental factors that contributed to this error. At-risk behavior, making a decision that unintentionally places the patient at risk, should be met with fair disciplinary action in order to correct the behavior and to mitigate the chances of it happening again. Then lastly, reckless behavior, making a decision that knowingly places themselves or others in harm's way. In this instance, this type of error is unacceptable and will not be tolerated. To simplify the key dimensions when establishing a culture of safety, here's a list of 7 aims to guide organizational efforts. Teamwork, deference or respect for everyone's expertise, readiness, and support. Evidence-based practice, this is to drive best practices, high reliability, and to reevaluate protocols. Leadership, being accountable, committed, and transparent. Communication, being assertive, collaborating during safety briefs, and conducting accurate and complete handoffs. Just, blame-free culture, non-punitive reporting, and focus on systems. Patient-centeredness, to empower patients, maintaining their focus in care planning and keeping them informed. And finally, continuous learning, which is facilitated through ongoing training, analyzing the root cause of operational failures, and contributing to quality improvement. So let's discuss how a root cause analysis can improve quality and safety. The RCA is used to determine how the negative outcome, or near miss, occurred. In its most simplified process, the inquirer would ask the 5 whys. Example, why did this error occur? Then ask why again, and so on. The clinical pathway of variables that may have contributed to the error can be multifaceted, complex, and comprehensive. To help organize these factors, a fishbone diagram can be constructed with the negative outcome at one end and variables that contributed to the outcome preceding. Here's an example of a case of a fishbone diagram. As you can see, the negative outcome on the right of the diagram is listed as a maternal death occurrence. The categories that hold potential risk are listed on the bone ends of the fishbone, such as patient characteristics, task factors, individual staff, work environment, organizational and management factors, and team factors. The key variables that exist in each category are listed and all fall as contributing factors to the outcome. Now that you have reviewed the basic principles and processes of practicing quality and safe patient-centered care, let's go over team processes within care teams. To better understand the capacity of our leadership role as frontline providers, we will determine the difference between multidisciplinary and interdisciplinary care. Ultimately, our goal is to bridge the communication gaps and unify care teams. We are accustomed to using the term multidisciplinary care in our healthcare system. This is the term we use for multiple care disciplines, individually working with the patient. The problems that arise from this framework is the limited collaboration between the disciplines, mainly as a result of them working in silos, creating disparities between patient goals, and the plan of care. Interdisciplinary is referring to the same multidisciplinary team, but instead they are networked between disciplines and collaboratively focused on patient-centered care goals. This is manifested through open communication between disciplines regarding the plan of care where everyone is on the same page. This is all facilitated and organized by the primary nurse who adopts the leadership role as the patient team care coordinator. The Patient Care Team Coordinator, PCTC, is simply the philosophy of the frontline nurse as a leader of the interdisciplinary team. Rightfully so, as the nurse is most attuned to the real-time progress of the patient's clinical status. This role emphasizes the integration of the multidisciplinary care team into a single coordinated unit. This will mitigate the potential of uncoordinated care, miscommunication, and care delays. The overall goal of the PCTC is to individually practice and coordinate all members of the care team to optimize patient-centeredness, maintain continuity of care, and maximize positive outcomes. That concludes our presentation on leading quality, safe, patient-centered care. I hope you found the information useful. Take care and be well.